From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to another episode of Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, as always, joined by Dr. Jim Salwitz. Dr. Salwitz, how are you?
I'm great, Chris. It's great to be back.
That it is another beautiful day in the medical neighborhood. And you look at our last episode of Medically Necessary, we went on hiatus right as COVID ramped up. Our last episode was our second special edition focusing on COVID. And it really was so what is this strange disease that we keep hearing about? And I think we might have a patient with it. Times have changed a lot in a short period of time.
Not only times, but I think the people have changed. I mean, I think this has been a remarkable transformation for all our caregivers, obviously from the hospital, our patients, our society. It's in December this year. It's a different world we're in now.
For those of you who are not part of our medical staff that are some of our subscribers and regular listeners, we have continued to do interviews throughout this surge. We've been doing interviews every single day. They've been a part of our internal video updates for our medical staff. So all of our clinicians, they've been getting their emails daily with videos that have these interviews in them. Now is the time to bring the podcast back, start sharing some information again, and take advantage of these different mediums that are available to us.
Absolutely.
Our first guests today, Dr. Sheraz Siddqiui, the Chief of Hospitalist Medicine at Robert Wood Johnson University Hospital, and Dr. Mafudia Suaray, who has been one of the clinicians leading the charge against the second surge in COVID-19 here at RWJUH. Dr. Siddqiui, Dr. Suaray, thank you for joining us.
Thank you for having us.
I think it's a really important place to start coming back, if you will. I think this is your team has been absolutely key in our response to this infection at Robert Wood Johnson, and has done such a tremendous amount of good work. So we're thrilled to actually start our series again, with you. It's the right place to begin.
No, thank you. Thank you for that. And I think everyone's been continuing to work really hard since March. I think looking back, we went down a little bit, but we've really picked it up again over the last couple of weeks. And I've been really fortunate to have a team of leaders that have really taken charge of this whole process. Dr. Suaray, Dr. G, and Dr. Khalil have really been a three-headed monster that have helped educate us. They started a team page, a Microsoft team page with a lot of valuable information that we've been sharing with all the other clinicians that have started to help us this time around. A lot of the community hospitalists have joined us this time around. Dr. Khan's, Jalil, Drs. Maganti, Sandhu, and Patel have really helped us out with this search. And, like I said the first time, we're very blessed to have the resources that we do at this hospital because it makes tackling this a little bit easier.
With this surge, when we talk about the second surge, we look back at March, April. In the state of New Jersey, we were seeing fewer cases reported every day compared to where we are now. The last several days, record levels of cases reported in the state. Hospitalizations in the state, though, were more than double what they are now. At Robert Wood, we're at only about a third of where we were at the peak. So what has changed? Why are we seeing so many more cases yet so many fewer hospitalizations? Why do you think that's happening?
I think we know a lot more about the disease. So there's probably, when people test positive or when people have symptoms, there's probably a little less panic to rush to the hospital. There's a whole lot more outpatient testing that is being done. One of the things that I noticed, for the past few months on the COVID services, many of the patients coming in have had at least one COVID test in the week or so before they come into the hospital. So I think that's keeping people home a little bit. They've been tested earlier on, they know their status, and a lot of them are engaged with their primary care doctors to try to manage their symptoms at home and come into the hospital only when they're having more serious symptoms. I think that may have played a big role in, the way the curve has been, not that huge peak, but a little bit slower incline, I think.
And specifically, are there any particular outpatient therapeutic strategies from your end that you think may be impacting this?
To be honest, I know that a lot of patients that are coming in are reporting that they've been treated with antibiotics. Some have been treated with steroids before they came in. Now, we don't have any evidence that these antibiotics are going to do anything because this is a viral infection. But maybe some of the steroids, could be doing something for some of these patients. I can't say for sure. We do have, now as of couple of weeks ago, we now have the monoclonal antibody. Not many people have received it because it's very limited supply. So, we don't really have, I can't really say that as, I don't think we've seen any impact from that yet. There's hope that that would also help in the future decrease the number of hospitalizations from COVID. But I really believe that it's people being more aware and understanding a little bit more the process, the way this disease progresses, and knowing what supportive measures to initiate at home. I honestly think that probably plays the bigger role as opposed to antibiotics or whatever that therapies that people are getting. Because a lot of the stuff that people are still using, we now have more evidence that it doesn't really work.
What I would just add to that is that first surge had an older patient population with a lot more comorbidities, whereas the patient population that's coming in now is probably 10 to 15 years younger on average.
Wow.
So you have people with less comorbidities, better testing, so they're aware of their diagnosis in advance, and they're coming in at the first sight of something not being right. A lot of these patients have pulse oxes at home, which that didn't happen the first time around. They are in touch with their primary care doctor, who's aware of their diagnosis and is advising them with what they know at this point. And I think they're showing up to the hospital at a much earlier time period compared to what we saw in the first surge, thereby, utilities like dexamethasone and remdesivir are a little bit more effective than when patients are coming in when they can no longer breathe. I mean, the first surge, we're seeing patients come in, maybe put on a high flow, and literally intubated within hours later and going to the ICU. Yeah. We do not see that this time around. This time around, they're coming in, they're staying on the floor, they're getting their few days of remdesivir and dexamethasone and being discharged home. So this is a very different course, a very different patient population than the first time. So I think if we look at the education people have received and the therapeutics we have, I think that's what's adding a little bit of a different curve to this surge.
And you talk about people coming in earlier in the disease course. There's a very different attitude this time around as compared to the first surge, just in coming to a hospital. That public fear of coming to a hospital that we saw in March and April that really kept, we saw the anecdotal stuff of people who came in, the number of burst appendices that we would see, people who delayed care before coming to the hospital. That has really changed in this surge.
Right. I think that's what's shocking about this surge, that the non-COVID patient population is still coming through the doors. The non-positive patient is still coming to get whatever diagnosis they have treated. They're not staying home anymore. So we're battling a high census in the hospital on the non-COVID side. Meanwhile, we're building up this COVID census, which is very different than the last time. The last time you saw a complete drop-off of that non-COVID census.
So let's look at the other side of the bed rails, if you will. How are caregivers doing? First of all, using a little bit different structure for your teams this time, I believe. But then also, where are people's heads at this point?
I'll say being on the floors the past few months, the caregivers are tired. They're tired, but they're also more confident because they know what this disease looks like now. They in the beginning, I remember in the spring surge, we really didn't know what to expect, and everything was just shocking how fast people were progressing, and we would try we're figuring things out as we went along. Now we know the trajectory. We know the early signs. So when someone is decompensating, we know what our next step would be. We know what our next step it would be. And so that part of it, gives the confidence in what you do. But on the other side, it also is exhausting because you've been doing this for so long, and especially for our nursing staff, because we never really totally shut down from COVID. We always had, a COVID unit with, with some COVID census going even in the summer months. So these nurses have been doing this, since March, without, too much break. So that part of it is exhausting, but there's a part of where we're seeing more people surviving. We're seeing less deaths, I should say. We're seeing less people dying. We're not sending people to the ICU as frequently as, Dr. Siddqiui mentioned before. People were coming in and within hours they were intubated. We're not seeing that, so much more. We actually are co-managing all the other medical, issues, I think, a little bit more effectively because we have a better handle on managing the COVID aspect of it. So it's a mix of emotions that, I would say. There's the confidence, and that, makes you feel good that you know what you can do to help someone. And then this, I wish I really didn't have to be doing this still, that, this thing was all over by now.
I think, in March, April, it was, let's go tackle this. Let's all work together. And everybody had a lot of adrenaline pumping. I think just like Dr. Suaray said, there's a lot of fatigue now. We didn't get that chance to kind of walk away from this that one would hope to have go away on a vacation for a week, or, just clear your head. The fact that you can't go away anymore, obviously that hurt us big time. But I think that ability to walk away, clear your head, and kind of get your head back together, I think we lost that, or we never got to go to that. And that's why you're seeing a lot more fatigue in nurses and physicians and techs and anybody else providing care for these patients, that it's just been going on since March. It just never stopped.
What can we do to help?
I think right now, with the community hospitalists and the community specialists coming on board as well, I think that kind of enlarged the umbrella for the number of people that we could have work on these services. It would be great if we can give people a little bit of time away from here, but as of now, it's all hands on deck. We started another COVID team. We're up to 5 teams last Thursday. We're probably going to start another one on Wednesday because the volume has picked up so much. And if it goes at the current level, we're probably starting a new team almost on a weekly basis. What people can do is stay away from each other. I think we're all very scared of that Thanksgiving bump. We're all expecting a bump from Christmas and New Year's. So, I think we're thinking that by mid-January is when we're going to see the peaks potentially happen for this. And what I would suggest to everybody that's listening to this is wear a mask and socially distance. I think doing that now will pay dividends for us to be able to get past this sooner. The sooner we all do the mask and the social distancing and stay away, the sooner we can get back to what somewhat of a normal life will be sooner. The longer we continue to do the interactions and meeting in big groups and things like that, we're pushing that ball further down the field, and we're not going to get through with this stuff. So that's my biggest wish for everybody, just to hunker down for the next month or 2 months. Let's get past this part, and then hopefully with vaccines and things like that, we can get past it sooner rather than later.
And I'll add just, to address the emotional side of it, is in as much as we're all tired, we need to be nice to each other. We need to continue to be nice to each other and continue to be supportive of each other, and be really mindful of, sometimes I think we forget about, as doctors, we might forget about the other people who are just as affected. Probably even more so, like the nurses who spend way more time with the patients at the bedside, the techs who are really, providing that personal care. I think we need to remember to be nice to them and to remember to just thank them and just show our appreciation. It really goes a long way. I think it was last month or so, the Schwartz round, since we can't, have it anymore in the, the big congregation, they actually did a mini Schwartz rounds on in South Building with the chaplain, and just allowed the staff to just share their feelings and emotions over what was going on, and it was really beautiful, and the staff really appreciated having that opportunity to process and to kind of debrief in a sense what's going on. And I think all those, little things that, are invaluable in helping us deal with the COVID fatigue. So a lot of us, a lot of staff, we're not just dealing with the stress of it at work, but we're dealing with it at home. There's a lot of people who have family members who've got COVID, who've lost family members, to COVID. And, it really wears you down when you're dealing, with it on all fronts. So just being there for each other and being supportive of each other, especially at a time like this. The holidays are hard on everyone, especially if you've had a loss. So this is a time that we all really need to pay attention to the emotional health, of all, for all of us. We need to pay attention to our emotional health. We need that to, to pull through.
Well, Sheraz, Mafudia, I mean, your observations are really wonderful, powerful. Obviously, it's really critical about what's happening and what we're doing here. It is an all hands on deck, but we have to treasure the people we have. And while we're making success, it's at, a real cost to our people, and we have to take care of them. So I really appreciate those observations, just as we appreciate your hard work, your leadership, your wisdom. It's a remarkable time in our lives, and you guys are, doing an incredible job. So thank you so much. And we really appreciate taking the time to do this. Another thing in your day, another tiny bit of energy exhausted and drained out. But we hope your words maybe feel and feed other people and help them get through a little bit better. So thank you so much.
Thanks for the opportunity. And hopefully get to do this again. It's always enjoyable to have you and Chris do these things. We all enjoy watching them. And we're going to miss them when you step down.
No, I'm not that easy to get rid of, though.
Dr. Sheraz Siddqiui, Dr. Mafudia Suaray, thank you for the time, giving us some insight as to what it is like on the med-surg floors in this second surge of COVID-19. Talking a little bit about how fewer patients are going to the ICU. So coming up, we'll hear about how things are different on those ICU floors with Dr. David Fischler. We'll be right back.
As part of RWJ Barnabas Health, Robert Wood Johnson University Hospital has a nationally ranked heart transplant program, is at the forefront of innovation in heart surgery and research, and has nationally recognized cardiac programs for excellence in transcatheter valve replacement and minimally invasive surgery. So get your heart checked, because your heart doesn't beat just for you. Robert Wood Johnson University Hospital. Let's be healthy together.
Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff.
Welcome back to Medically Necessary. And we do sound a little different, I'm sure, than you may remember from the first two seasons we had of Medically Necessary. It is COVID. So we are observing social distancing. As you watched the video updates that we had during the first surge, we were observing social distancing then. We continue to now take advantage of that remote technology that exists. And we look forward to the day that we are back in the podcast studio and seated side by side, almost shoulder to shoulder. But for now, we'll continue taking advantage of the technology as it exists. Right, Dr. Salwitz?
Yeah, it's not really a podcast at this point. We're pod light. Pod light. So we're like the flowers now are going through the wind. We can't actually be in the pod next to each other or something.
It feels very wintry in that analogy, I guess you could say. Our next guest today is Dr. David Fischler from the Pulmonary and Intensive Care Specialists of New Jersey, one of our MICU leaders. Dr. Fischler, thank you for joining us. It's a pleasure to have you with us.
Happy to be here.
We just spoke with Dr. Siddqiui about what we're seeing in the med-surg side of things here in this second wave of COVID. The ICU, I think we're seeing an even bigger change than we did in the first surge. So back in mid-April, we had, on average, more than 60 patients in the ICU. We peaked at, I believe, 66 patients during the first wave. Over the past week, we've really been at about 10 patients in the ICU. Is that right?
Yes. With COVID, yes.
And mortality rates have also been down. We had multiple expirations per day during that first wave. Now, a couple, a handful a week, if that. Why do you think we're seeing such a change?
So this is a very interesting discussion. There's a lot of different academic medical centers who have actually looked at this, and I think they sort of all agree that we really had no idea what we were doing when this happened the first time around. We tried medicines that weren't working, and at the time, we really tried to do things differently, thinking that this was a different virus. And then one of the advantages of having the flattening of the curve and the quote unquote quiet summer is that we really got a chance to decompress, ask ourselves what worked, and then some data obviously came out. So patients are coming in, they're getting remdesivir, steroids, and anticoagulation immediately. And these are things that weren't actually being given at all at first when they came in last time. So I think obviously with time, we've gotten better at what we're doing. I do think, though, that a lot of this has to do with numbers. I do. In March, those numbers went up so fast, and thanks to our friends in the medical school and the hospital, came up with these amazing, surge plans to expand ICU capacity. But the truth is, we didn't have enough doctors with critical care experience who felt comfortable really doing what they needed to do. Everybody did the best that they could, but as numbers went down, those people that were responsible for this really had a time to take a deep breath and say, all right, what works, what doesn't? So going into this second wave, I think we're all much more prepared than we were before. I also think the patient population is very different, and that's really been seen across the board in a lot of these studies. We really couldn't protect our vulnerable population in the rehabs and the nursing homes back in March and April because of a lack of PPE, a lack of foresight. I mean, a lot of my friends who work in these long-term care facilities, employees are tested multiple times per week. The patients are being tested multiple times per week. They now all have adequate PPE. So the people that are getting admitted aren't these really old, frail people from long-term facilities. We're seeing much younger people with less comorbidities. And those people, by looking at the statistics, clearly do better than those people who are older and frail or with more comorbidities. So I think it's the patient population that we're seeing as well.
Any difference in the kind of illness we're seeing?
I think we're not seeing the explosive thrombophlebitic things that we saw at the beginning. That was the thing that I remember freaking me out the most, was all these clotting syndromes, strokes, clots in the heart, massive pulmonary emboli, because nobody really knew what to do in terms of anticoagulation. I think first and foremost, we're not seeing those thrombophlebitic disasters. I think also, one of the things we have to look at ourselves as a critical care department is that we really weren't great at flipping these people over and proning. We just didn't do it as much as we should have. And now, the minute these people come in and they're hypoxemic on oxygen, we're flipping them over and paralyzing them, and they're getting better. So if you remember, in March and April, we had a proning team, people that would specifically come and help us flip these patients over to improve gas exchange. Now, we don't have that proning team, but we are leading towards that much earlier than we were. But the truth is, Jim and Chris, we're still seeing that explosive ARDS patient like we did before. I just don't think we're seeing as many. I don't think we're seeing them as old and as frail. And I think right now, at least during the summer and now going into the surge, we've got enough staff and we've got enough beds. A lot of this has to do with numbers, bed availability, and how we manage the surge. I mean, I think a lot of these other states are now going through what we went through in March and April, where they just don't have anybody to help, And I think, this time we've got a lot more people ready to go who can absolutely, step up and care for these people in as good a fashion as anybody else who's doing critical care.
How are people doing as far as holding up through this?
Well, let me just say, and I'm sure you're going to beat this out, but that COVID really sucks. We are all burnt out. All you have to do is walk down into RCU South Building, now 4 West, or speak to the MICU and CCU nurses. Everybody's fried, and you do your best as a ICU leader to try to cheer them up, buy them food, remind them that this will all go away. But I think we're all really fried, but we don't have a choice. We have to step up and care for these people. I think some of us are hopefully going to see some light at the end of the tunnel with some of the vaccines coming out, and also hopefully removing some of the political nature of what's gone on with this disease. To me, I'm just hopeful we'll have a little bit of breathing room by summertime. I've accepted that this is just going to be 6 months of pain and suffering, but the staff is burnt, and I think our administration has recognized it, and they've done everything they could. And I know our medical school friends have recognized it, and they're doing everything they could. But this is what we signed up for. This is what we have to do. But I apologize for the language, but that's as honest as I can be. It's just, that's what really sucks about it. It's just every day is just hard, and there's very sick people, and the hardest thing, and you know this very well, Jim, is that we're also trying to stay open, doing normal stuff while this is going on. Offices are open. We're trying to keep our office patients going. We're seeing regular hospital stuff. In a way, it's actually harder because we're trying to stay open, but we have to. We don't have a choice. We can't shut down like we did in this fall and spring because of backlogs of surgeries, people that need care. Obviously, things are very different with our increased testing capacity and the things that we've seen, but in a lot of ways, I think a lot of clinicians, both nurses and doctors, are saying it's harder because we're doing regular stuff too.
That was actually going to be my next question, is what it's like trying to manage COVID patients at a time. I mean, during the first surge, MICU, CCU, they were 100% COVID. And now, obviously, both units are still maintaining their regular patient population as well.
There's definitely a sense that the numbers are better because we're also not seeing 14, 15 straight COVID patients. I'll be the first to tell you, I was in the ICU end of April after I recovered, and I could tell you that it was really hard motivating the team, the residents, the nurses, myself. Every patient had the same stuck disease, wasn't getting better. At least in some way, having other ICU stuff does keep it fresher. Obviously you don't get as burnt out on it, but yeah, I mean, you're definitely seeing that you've got to be on your game for the regular stuff. And Dr. Salwitz knows this very well. We're taking care of all these office patients who are recovering from COVID. We're taking care of patients who are now getting COVID, all asking for infusions, asking for steroids. I mean, there's enough stuff out there that you basically have to counsel everybody who calls in with the diagnosis to make sure they know that they just got to stay home and get better.
What should we be doing for our people, for our patients that maybe we're not quite getting there yet? How should we be improving?
I think having less political hot stuff going on will help. That really drowns out a lot of the nonsense. I spend half my time talking people into the vaccine when it comes. I think we as a physician community, a hospital community, a medical school community, we're going to assume that there's going to be vaccine distribution here. We got to do a really good job of getting that word out. I mean, I can tell you, even yesterday, I was on 4 West with the nurses who are back in a COVID unit. I must have talked 3 nurses into taking the vaccine. We got to do a really good job of telling people that, why did the vaccine get done so fast? They think people cut corners. I believe it's because this is all the companies have been dealing with. They put every one of their brightest minds on this, every single company. No wonder it went faster because everybody was working on it. Like, none of them even thought about that kind of possibility. I think we got to do a good job as this vaccine stuff comes out to get everybody vaccinated so we don't have a backlog of people who needed to get it first. Because if we can keep everybody healthy from the healthcare perspective, then we'll be able to stay at work, get everybody through, and we can start telling our friends the story. I got the vaccine. It was fine. You need to take it. Because I'm telling you, the thing that worries me the most about our ability to get through this is that the vaccine is going to be ready and so many people aren't going to take it because they just don't trust it. We have to lead the way in that, in my opinion.
Well, Dave, the bad news is you're definitely not going to be the first person to get it because I'm going to be one step in front of you.
I understand. I just checked. I have antibodies still after my infection in March. I will take a number and let you and anyone else who needs it get there. That is fine with me.
I do think it's so critical people understand this is a no-brainer. Vaccine technology, we understand. And we also should understand how deadly this virus is. And this is the way that we win the war, to quote Dr. Anthony Fauci.
Right. Absolutely.
Exactly. And, I'm sure a lot of people look at the mRNA vaccines and, there aren't mass vaccines that are out there that are mRNA, but it's not like this is new technology. This has been studied for decades. And you read it, Ebola was, we were very close to an mRNA-based vaccine for Ebola. So it's not like this is truly brand new technology. This has been studied.
Right. And in a way, I think it's good that they haven't gotten too much word out about vaccine development because it would have been politicized. Now, hopefully they could say the vaccine's ready and this is what it is. And this is what it's going to do. And this is how fast it's going to get us back to somewhat normalcy. Get your kids back to school, get colleges opened again. You know, a lot of doctors actually get a vacation and actually go on a plane safely. These are all the things that we need to get out there. I mean, I also think, you know, we're a little bit lucky. We're in a state where I do think a lot of people are masking up, and we're not worried about the politicization of people wearing masks. I do believe that at least our state, that is one of the reasons that we're not doing as bad as other states. And of course, I'm hopeful people will continue that.
An unfortunate hard lesson learned from the first surge.
Absolutely.
Well, Dave, thank you very much for your hard work and for your wisdom and for your teaching today. It makes a tremendous difference, and we really appreciate it. Keep it up.
Okay. All right. Hang in there, everybody.
Dr. David Fischler from Pulmonary and Intensive Care Specialists of New Jersey. Dr. Salwitz, you know, it is great to be back on the podcast airwaves, if you will, with you once again.
You know, it's funny, 'cause it works in COVID, but we just had other things to do.
Exactly. And, you know, we adjust as we go here. We learn what works and what doesn't, just as we have with every other aspect of COVID. We learn what works and what doesn't. So it's good to be back on the podcast airwaves. Don't forget, if you haven't already subscribed, you can subscribe anytime. Apple Podcasts, Google Play, now YouTube Podcasts as well. And we also have a link to Medically Necessary available on the medical staff portal. All the episodes, you can go back over a year now from when we launched the podcast. You can hear every episode right on the Robert Wood Johnson University Hospital medical staff portal. For Dr. Jim Salwitz.
For Chris Hoenig.
Thank you for listening.
Stay healthy.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.